From the data thus far, we have over a 5-year period trends in how physicians are managing patients with atrial fibrillation, and what we see is a marked increase in the proportion of patients at risk for stroke from atrial fibrillation who are now being prescribed anticoagulants. And we also see over this 5-year period of observation a marked decrease in the use of warfarin as an anticoagulant and a marked increase in the use of the novel oral anticoagulants. Well, this is important because Garfield AF is now the largest registry of atrial fibrillation in the history of medicine. The updated guidelines, which were just released now at the ESC here in Rome, are outstanding. They state more clearly than ever before that patients who are being anticoagulated for stroke prevention in AF should receive NOACs rather than warfarin. They state more clearly than ever before that aspirin should not be used in an attempt to prevent stroke from atrial fibrillation. And I think these will resonate in the healthcare provider community. Well, Garfield differs from other registries because Garfield really recruits centers in a way that's proportional to the types of practices in a particular country. Garfield is global. Garfield importantly insists that patients entering the registry have atrial fibrillation diagnosed within a 6-week period. During the 2-year follow-up based on Garfield data, the number one cause of death is cardiovascular death, and that includes myocardial infarction and congestive heart failure. I think what came to us as a surprise is the important role that chronic kidney disease plays in adverse outcomes. In the first 4 months, the higher mortality was driven by the subgroups of cardiovascular death, of stroke, and of chronic kidney disease. Early mortality is driven by the probability that atrial fibrillation is a systemic illness. It manifests itself on the electrocardiogram and can be diagnosed, but it's probably a surrogate for patients who have many adverse health risk factors, such as diabetes or obesity, occult cardiovascular disease, and we believe that as we probe this observation more carefully and as we have longer follow-up, that we may gain new understandings from this observation of the spike in early mortality during the first 4 months in Garfield AF. Well, I think that early mortality is something we as a healthcare provider community need to work on in order to reduce this spike, this unexpected spike in the early death rate. And I think that it really calls for better integrated healthcare systems and looking at the patient far beyond the narrow focus of whether to anticoagulate and what anticoagulant agent to prescribe. I think that when we see atrial fibrillation, new onset, we have to say to ourselves, uh-oh, there's a problem here, and we have to do a thorough evaluation of all aspects of the patient for risks for early mortality. The symposium presentation, I think the most single important take-home message is that Garfield has come up with a new risk score that appears to be in every way superior to that of the CHADS-VASC2 scoring system. And this will probably be published rapidly, and we'll see whether it really is accepted by the healthcare provider community, but it has the possibility of predicting with much greater accuracy which patients with atrial fibrillation will succumb to stroke, and importantly, which patients with atrial fibrillation are at low risk for stroke.